Hi, my name is Joo Ha Hwang. I am the Section Chief of Gastroenterology at Harborview Medical Center with the University of Washington in Seattle. I've been asked by the editors of GIE to provide an interview and discussion regarding a recent review that we submitted and has been accepted for publication in GIE entitled Screening and Surveillance for Gastric Cancer in the United States, Is It Needed? My co-authors are Gwang-Ha Kim, Peter Liang, and Sungjo Bang. And the editors asked me to provide some discussion regarding the motivation for this review and then to highlight some important features of the review. The inspiration for this review really came when I moved institutions from the main University of Washington Medical Center over to Harborview Medical Center. Harborview is a county hospital known for trauma care and also for being a safety net hospital. So there's a large immigrant population here, particularly from Asia. And as I began my practice here, I noticed that there were a lot of patients who had intestinal metaplasia in the stomach. And we had extensive discussions on how do we need to manage this? Does this need to be surveyed? Do we need to be worried about these lesions? And we went to the literature and kind of all over the map regarding the management of intestinal metaplasia in the U.S., although it's a little bit more clear when we go outside of the U.S. And so I wanted to focus this review on the issue of gastric cancer screening, who's at risk, focus on intestinal metaplasia a bit, and then to propose some screening guidelines or recommendations, not guidelines. There's clearly similarities between intestinal metaplasia and of the stomach and of the esophagus or Barrett's esophagus. These are clearly premalignant lesions that then can progress onto dysplasia and cancer, although not all do. And so the important thing is to find out who's at risk and to identify those patients and then to survey them appropriately. Interestingly enough, although we think that gastric cancer is very rare here in the U.S., at 25,000 cases per year, esophageal cancer is actually even more rare than gastric cancer, with only 17,000 cases a year. And we have pretty clear guidelines regarding screening and surveillance for esophageal cancer and surveillance of Barrett's. But we don't have any real clear guidelines on gastric cancer, even though there are more cases. It turns out that the ASG actually does have some recommendations or suggestions regarding screening EGD for gastric cancer in new immigrants to the U.S. who come from high-risk regions, and this is described in their Standards of Practice document on ethnic issues in endoscopy. There's also suggestions regarding surveillance of endoscopy, using surveillance endoscopy to follow intestinal metaplasia in patients who come from high-risk regions or who have family history. So there's some recommendations that are out there, but they're obscure, and there continues to be confusion regarding who should be screened and at what intervals. So although this review isn't a guideline, I hope that it does increase awareness of the need to identify those patients who are at high risk and might benefit from gastric cancer screening. And my overall hope is that eventually we can move towards establishing national guidelines so that reimbursement becomes easier for these patients. There's clearly some disparity issues with this, with a minority population being at greatest risk, and at substantially higher risk, I should say. The other main motivating factor for writing this particular review has to do with the increasing interest in endoscopic submucosal dissection, or ESD, and myself included, I find this to be a fascinating procedure with a lot of potential, but the problem is in the U.S. I see that ESD is being performed mainly for Barrett's esophagus with dysplasia or intramucosal carcinoma, or in the colon, where the greatest utility of ESD really is in how the Asians are using it, and it's really for gastric cancer. And the reason being is in the esophagus and the colon, I think we can agree that we see these lesions quite well, especially the margins. But in the stomach, we really do have difficulty with current imaging methods to identify the margins of these lesions, and oftentimes they can be invasive so that we can't identify them endoscopically. So this is where en-bloc resection is critical, so that we take out the area that is concerning and remove it en bloc so that we can assess the lateral margins. And so for gastric cancer in particular, ESD is an important intervention. But in order to perform more ESDs here in the U.S., we have to find earlier lesions. We need to find gastric dysplasia, high-grade dysplasia, and early gastric cancers that are amenable to endoscopic therapy. And the only way we're going to do that is somehow to establish some screening mechanisms for gastric cancer. And so the goal for this particular review is to identify what the risk factors are and to identify a population that might benefit from gastric cancer screening and then to propose an algorithm to follow those patients who are at high risk. So in terms of the review, the main highlights really are the identification of the risk factors. And the most prominent risk factor obviously is race and ethnicity. I'm showing you a map here right now that can be found online that shows the incidence of gastric cancer worldwide. And you can clearly see that there are certain regions that have a much higher incidence than the rest of the world. The most pronounced difference would be between South Korea, which has an incidence of 62.2 per 100,000, compared to the US, which is only at 5.7. So there's over a tenfold difference in the incidence of gastric cancer in these different populations. And since the US is a country that has a large immigrant population, I don't think that we can ignore where these patients come from, and we need to take that into consideration when we're managing these patients. Other risk factors included H. pylori infection, family history of gastric cancer, and the presence of intestinal metaplasia. And this gets us to the appropriate screening methods. There's been several screening methods that have been evaluated, including upper GI series, serum pepsinogen, as well as H. pylori testing and endoscopy. In this review, we favored the use of endoscopy, and the reason being that endoscopy allows us to directly examine the gastric mucosa, evaluate for subtle lesions that we know are associated with dysplasia and early gastric cancer, and the ability to perform biopsies. And we know that intestinal metaplasia, and probably the extent of intestinal metaplasia, is a major risk factor for gastric cancer or the development of gastric cancer in the future. And again, this can only be identified by endoscopy. And furthermore, endoscopy is the favored method for screening in both Korea and Japan, where national programs exist. The issues with endoscopy in the U.S. Include the cost. It's much more expensive to perform endoscopy in the U.S. than anywhere else in the world, especially Asia. So there's a question of cost effectiveness with this strategy. In addition, further training is required to identify subtle gastric lesions, and it takes a lot more time. These procedures are not the quick EGDs that are used to catch up when you're behind doing colonoscopies. There's a nice study that demonstrated the more time that you spend in the stomach, the more likely you are to identify a high-risk lesion. And it probably has parallels to withdrawal time on colonoscopy and finding polyps. And also in regards to advanced imaging techniques, it might also be time that is explaining why we're having higher yields with some of these advanced imaging techniques, because by using these advanced imaging techniques like NBI, other digital enhancements, or chromodoscopy, you're spending more time doing the examination. So we've proposed an algorithm based on the review, based on the data that's out there. It's in Figure 3 of the manuscript, and we welcome you to review that. We certainly would welcome any comments. We don't think that it's a perfect algorithm, but it's a start, and it's intended to be a start, and we hope that This will advance the issue of gastric cancer screening here in the U.S., of which we feel there's ample data to support starting that in select high-risk populations. So to wrap this up, I appreciate the invitation from the GIE editorial board to comment on this review. We feel that this is an important topic. There's a population out there that is at high risk and should undergo gastric cancer screening, and by doing this we'll identify more lesions that might be amenable to endoscopic therapy. So for those of you who want to do more and more ESD, you got to get the word out to increase gastric cancer screening so that we can identify these lesions at an early time point, or we can intervene with our endoscopic therapies. So with that, I'd like to thank you for your time, and to thank the GIE editorial board for this opportunity. Thank you.